Episode 33, Labored Breathing with Left Upper Quadrant Pain. Welcome to Sports Medicine Case Studies, where I review published case studies, discuss key takeaways, and provide some practice questions. Here's the case. A 21-year-old male Division I college football player suffered a blow to the left side of his torso with approximately 3 minutes remaining in the fourth quarter. He did not participate further in the event beyond this episode. He was later observed on the sideline with labored breathing and complaints of left-sided upper abdominal pain and left-sided rib pain. Symptoms were exacerbated with movement and inhalation. The head athletic trainer did not think it was an urgent issue, but rather a mild musculoskeletal injury. The medical team was later informed the patient had nearly collapsed in the shower after the game with worsening symptoms. At this point, he was immediately transferred to the emergency department. On evaluation there, vital signs demonstrated a blood pressure of 105/67, a pulse rate of 92 beats per minute, a respiratory rate of 20 breaths per minute, and pulse oximetry of 96% on room air. He had pain and tenderness in the left upper quadrant and the left lateral ribs between T8 and T10. The lungs were described as clear to auscultation bilaterally. My differential diagnosis, and this is supplemented by the authors: chest contusion, rib fracture, pneumothorax, splenic injury. I'd like to recognize the authors. This case was presented and published by Dr. Ceus at the 2018 Baptist Hospital Scholarly Showcase. I'm Scott Hull, a primary care sports medicine physician, and I am studying for my sports medicine certification exam in 2026, and I hope you'll join me on the journey. This podcast is for educational purposes only. Okay, imaging. In the emergency department, a CT scan of the chest was obtained. It showed small left lung contusions, acute, minimally displaced fractures of the left 6th, 7th, and 8th ribs, and a 30% left-sided pneumothorax. A left-sided chest tube was placed in the ER, and the athlete was admitted to the ICU for further observation. After hospital day 2, a chest x-ray showed complete resolution of the left-sided pneumothorax, and the chest tube was removed. He was discharged home in stable condition, and on follow-up, he began a gradual return to play, which involved low-impact aerobic conditioning for 1 week, followed by non-contact regular activity for 1 week with a protective jacket, and then full contact regular activity with a protective jacket. He was cleared to play in a football games 29 days after his traumatic pneumothorax. He participated fully with no in-game complaints after return to play. So a couple of questions I had as I read through this case report. Number one, I noticed some uncertainty about communication between the head athletic trainer and the rest of the medical team. That wasn't further explained by the authors, and I did not see a report of an initial chest x-ray from the emergency department. Couple of key takeaways I noted from this. A pneumothorax in athletes encompasses both primary spontaneous pneumothorax, which is the most common type in this population, and less frequently traumatic pneumothorax from contact sports, like in this case. Management is guided by clinical stability and symptoms rather than pneumothorax size alone, with treatment ranging from conservative observation to surgical intervention. Couple of key principles. With clinically stable, mildly symptomatic spontaneous pneumothorax, conservative care with observation and potentially supplemental oxygen is conditionally recommended, according to recent evidence-based guidelines. Symptomatic or large primary spontaneous pneumothorax, needle aspiration is recommended over chest tube as an initial interventional treatment. A tension pneumothorax requires immediate needle decompression. Traditionally, this has been taught at the second intercostal space at the midclavicular line. Subsequently, I've read about using the fifth intercostal space at the mid-axillary line, followed by tube thoracostomy. Recently, I was doing a practice question which asked about a treatment for a tension pneumothorax and asked which was the recommended treatment, the second intercostal space at the midclavicular line, which is what I was taught when I was in fellowship, or placing a needle at the fifth intercostal space mid-axillary line. And the correct answer in my practice test was the fifth intercostal space. So just for your information. For traumatic pneumothorax from contact sports, small or pneumothoraces can be observed, and approximately 90% are managed conservatively and will not ultimately require subsequent chest tube insertion. Tube thoracostomy is indicated for hemodynamic instability or respiratory compromise. With a spontaneous pneumothorax, recurrence is a central concern for athletes, and approximately 25% of individuals with a primary spontaneous pneumothorax will experience an inpatient-treated recurrence within 5 years, with 3/4 of these recurrences occurring in the first year. Regarding return to play and activity after a pneumothorax, there is no sport-specific guidelines that I could identify for return to play, but there are general principles which have been described by the American College of Sports Medicine, which emphasize confirming anatomical healing, restoration of sport-specific skills, and psychosocial readiness. That follows the approach that the author took in this case study. There are additional pragmatic recommendations which I'd like to review. Radiographic confirmation of complete pneumothorax resolution before resuming activity is reasonable, and then there is a special case of scuba diving which should be permanently discouraged according to current guidelines unless definitive surgical pleurectomy has been performed. There is no strong evidence to support restricting activity after pneumothorax resolution, though shared decision-making regarding recurrence risk is appropriate. Okay, couple of practice questions for you. Question 1. A 19-year-old male basketball player who is 6'4" and weighs 155 pounds presents to the athletic training room with acute onset of right-sided chest pain and mild dyspnea that began during practice. His vital signs include a heart rate of 88, a blood pressure of 122/78, a respiratory rate of 18, and a pulse oximetry of 97%. A chest x-ray reveals a moderate right-sided pneumothorax. He is clinically stable and only mildly symptomatic. According to current evidence-based guidelines, and the ones I'm referring to were published in 2024, and they're in the European guidelines. It's reference 3 in my references. So according to this guideline, what is the recommended initial management approach for this patient? A, immediate chest tube insertion. B, conservative management with observation and supplemental oxygen. C, needle aspiration followed by discharge if successful. D, emergency video-assisted thoracoscopic surgery with bolectomy and pleurodesis. And E, intubation and positive pressure ventilation. The correct answer is B. Current guidelines conditionally recommend conservative care for clinically stable, minimally symptomatic. A spontaneous pneumothorax trial demonstrated that over 90% of conservatively managed patients with moderate to large pneumothoraces did not require an invasive procedure, and if intervention is needed, needle aspiration is preferred over a chest tube. But conservative management is the first-line approach for stable patient. Question 2. A 22-year-old male soccer player collapses on the field during a match. On sideline evaluation, he is cyanotic with distended neck veins, absent breath sounds on the left, and hypotension with a blood pressure of 78/50. Tracheal deviation to the right is noted. What is the most appropriate immediate action? A. Obtain a portable chest x-ray to confirm the diagnosis. B. Perform point-of-care lung ultrasound. C. Needle decompression at the second intercostal space mid-clavicular line. D. Place a left-sided chest tube at the fifth intercostal space mid-axillary line. And E. Administer IV fluids and reassess. The correct answer is C. This presentation is classic for a tension pneumothorax, a clinical diagnosis that should be treated immediately without waiting for imaging. Needle decompression at the second intercostal space mid-clavicular line, or alternatively at the fifth intercostal space mid-axillary line, is the appropriate emergency intervention. This should be followed by definitive tube thoracostomy, and delaying treatment for imaging in the setting of hemodynamic compromise is inappropriate. Question 3. A 17-year-old cross-country runner is evaluated after his first episode of primary spontaneous pneumothorax, which was managed conservatively with complete resolution. He and his family ask about the risk of recurrence and whether surgery should be performed now to prevent recurrence. Which of the following statements regarding recurrence risk and surgical prevention is most accurate? A. Recurrence risk after the first primary spontaneous pneumothorax is less than 5%, so surgery is never indicated after a first episode. B. Video-assisted thoracoscopic surgery significantly reduces recurrence compared to conservative treatment, and early surgery is conditionally recommended for patients who prioritize recurrence prevention. C. Surgery should only be performed after the third episode of a pneumothorax. D. Chemical pleurodesis alone is superior to video-assisted thoracoscopic surgery with partial pleurectomy for recurrence prevention. And E. Recurrence risk is highest 3 to 5 years after the initial episode. The correct answer is B. Recurrence rates after a first primary spontaneous pneumothorax range from 16 to 52%, with most estimated at 3/4 of recurrences occurring within the first year. A systematic review found that video-assisted thoracoscopic surgery significantly reduced recurrence compared to conservative treatment. Current European guidelines conditionally recommend early surgical intervention for patients who prioritize recurrence prevention, and video-assisted thoracoscopic surgery with partial pleurectomy achieves lower recurrence rates at less than 2% than pleural abrasion or chemical pleurodesis alone. Okay, question 4. A 25-year-old recreational scuba diver had a primary spontaneous pneumothorax 6 months ago that was treated with needle aspiration and resolved completely. She now wants to return to scuba diving. Chest x-ray shows no residual pneumothorax. What is the most appropriate recommendation regarding return to scuba diving? A. She may return to diving immediately since the pneumothorax has resolved. B. She may return to diving after 12 months from the initial event. C. She should permanently avoid scuba diving unless she has undergone definitive surgical pleurectomy. D. She may return to diving if a CT scan shows no residual blebs. E. She may return to diving with a dive buddy and conservative depth limits. The correct answer is C. The 2024 European guidelines recommend that scuba diving should be permanently discouraged after primary spontaneous pneumothorax unless definitive surgical pleurectomy has been performed. The risk of recurrence at depth, where Boyle's law effects can cause rapid expansion of any trapped air, makes diving particularly dangerous after a primary spontaneous pneumothorax, regardless of radiographic resolution. Question 5. A 20-year-old male swimmer is diagnosed with a small traumatic pneumothorax after a water polo injury. He is hemodynamically stable with mild chest wall tenderness but no respiratory distress. His pulse oximetry is 99% on room air. What is the most appropriate initial management? A. Immediate chest tube placement. B. Conservative observation with serial imaging. C. Needle aspiration. D. Emergent surgical consultation. E. Discharge home with return precautions. The correct answer is B. For small, hemodynamically stable, traumatic pneumothoraces, conservative observation is appropriate. Evidence demonstrates that approximately 90% of conservatively managed traumatic pneumothoraces will not require subsequent chest tube insertion. Serial imaging and clinical monitoring are indicated to ensure the pneumothorax does not progress. Immediate chest tube placement is reserved for patients with hemodynamic instability or respiratory compromise. Thank you.